that sound fair?
Get the writing in.
Unit 2 in from your chapters is going to be 3, 4, 5, 6, and 7. 5 chapters, right? And look when that exam's going to be. It's going to be on Wednesday, next week. My, how time flies and we're having so much fun and testing. And then, of course, you'll probably be having tests with your pharmacology, right?
Yep,
That's the way it goes. That's just how it is. The stress, the rigor of academics and higher education, right? But again, you know how I operate, you've seen, and if you'll just follow the pattern, you should do just fine, right? That's just the way it is. This exam I have, because it's 5 chapters and it is indeed some intense content, I decided to make it a 50-item test, as you see on your blueprint, right? Mm-hmm. So that gives you a little more breathing room for errors.
Yes.
Chapter 3 starts off with the nursing process. Well, this whole statement's nursing process, but in particular, we're talking about the assessment phase. And I found that nice, neat little diagram on the World Wide Web to sort of allude to the nursing process, the nursing assessment, and all of those components are important as we think about the nursing assessment. We must have all of that. Some of you guys were in skills lab yesterday, and you had it was a quite intense afternoon. Well, it was quite intense for both morning and afternoon as we maneuvered through the ATI. We didn't have things loaded, but that's going to soon change. You'll get that stuff loaded. But in the afternoon, we actually dove into some of these aspects of the assessment, nursing process, and it's going to be a fun exercise, hopefully, for the guys that have to do their skills lab on Thursday and Friday. So, in all things, remember the assessment. That's the first step in the nursing process. And we know that that's systematic gathering of information. We're looking at that individual or maybe perhaps the group or community, and it does encompass all of these aspects of physical, mental, spiritual, socioeconomic, and culture. We're all-encompassing. We're holistic. In order to be the best nurse that we can possibly be, we must cover all these aspects. We must have the pulse on our patients or on our group that we're looking over, or even within, if you were a community health nurse, that demographic group of individuals. Very detailed PowerPoint slide there, right? But it talks about the process in whole. We start off what? The assessment is the first step of the process. Data must be accurate and complete. And you, the RN, is going to be responsible for ensuring that. You cannot delegate assessment. That will be on state boards. There will be some sort of scenario question related to a situation, and it will ask you, it'll be a delegation question, it'll ask you, what can you safely delegate to a nursing assistant personnel? In other words, i.e., that would be like the CNA or LVN or LPN if you live on the East Coast, right? You are responsible for the assessment, hands down. They'll even put questions, it'll almost trick you. But you remember, that's your responsibility. You cannot delegate that to lower cohort of your workers. You have to take care of that. What you also have to remember is, as you think about delegation, you best make sure that that's within their scope of practice. What can that CNA safely and competently do? You must make sure that that CNA is competent in their skills. If you know that they're not, then you should not delegate to that individual. Your job is to be a teacher to your workers, right? Maybe there's some sort of lack of understanding or knowledge, and you must go forth and actually train your your workers. The diagnosis. With the data gathered from the assessment, then you can start identifying what, in fact, is an actual or potential health problem under consideration with your patient. It's very vital, though, that you have, like I said, the correct information through the assessment before you can actually zero in on a potential diagnosis. Planning, and we talked about this even at the last lecture, planning, and this actually breaks down planning outcomes, right? And planning outcomes, according to your text, it talks to you about the patient's motivation, family, understanding. Is there some sort of cultural aspect that you must consider? And then it has this thing called planning interventions. Those things that you plan to do, you plan to consider to make it a positive outcome for your patients. Planning and implementation, or planning and interventions, they sort of go hand in hand. The implementation phase of the nursing process, that's your doing part. That's what you do. That's your action. You planned in the above step of what interventions you might do, and then the implementation, that's what you are doing. I walked in there and I gave my patient an injection of morphine. They were having pain. Something like that, right? Implementation, that's the action. I walked through the door. I did something. Implementation. Evaluation, and we must constantly be evaluating our patient, because we realize that perhaps our plan wasn't effective. It didn't work. We might have to rethink what we decided would work and change the whole plan, because things are just not coming along here. So evaluation, very important, and a lot of times we find that this has very little follow-up, unfortunately, but we're getting better at it. Subjective data. Subjective data, that's termed covert kind of data. Symptoms, it's what the patient's telling us, what the patient states. And we actually had a good exercise yesterday, Ms. Dutton talking about subjective and objective data. It's what that patient says. I like fried food, it's obvious. I like that Kentucky Fried Chicken. Well, actually, I'm thinking about switching over. There's a good restaurant that is it?
Filet.
No, not Chick-fil-A. There's a new chicken on the south side. Something chick. Yes, my husband uncovered that place, and he loves it. He took me to it. He says, and he'd already gone that same day, you know, in the lunchtime. And I got off work, and he says, "I want to take you to a new place," and so that he comes back again. You know. Sometimes we overindulge, don't we? But subjective data. Notice how I infiltrate some humor. It keeps y'all awake, maybe. Maybe not. But anyway, subjective data, that's what that patient's feelings are, what they're saying, right? And if you did go to your chapter 3, table 3-1, you could see some more examples. Objective data, observed. Remember yesterday, the ones that were in the skills lab? That was interesting how this just tied so nicely into the skills lab. And this Duck was even talking about objective and what's observed. You remember she said, I observed that patient grimacing. Y'all recall that was in the skills lab? Y'all remember that little segment? See how this makes sense? It's what we can observe or we can measure. I can measure a blood pressure of 120 over 68. That's objective data. The temperature was 99.6. Concrete objective data, right? I observed the person grimacing. X-ray results. I observed that skin color. I measured that urine output. I note that this patient's cholesterol level is being elevated. Objective data. Subjective is what? Anyone?
Thoughts, feelings.
Subjective?
Feelings.
What the? There you go. Objective.
Observe.
Observe. It's going to be very important as you all go forward with your developing of your care plans. That's coming down the road. And then you all can refer again to that same table to see examples or more examples. We have this thing, the sources of data. You have primary data, and that's really coming directly from the horse's mouth, the patient, right? And then you have secondary data, and that might be tied to referring to maybe you're reading charts. Maybe a previous admission, you're reading the patient's old records. Or perhaps a caregiver, right? When we talk about the types of assessments, they can be broad or general, they can be very specific. You have the initial assessment. Initial assessment is completed when they first come in. Initial, first time being seen. You have ongoing assessments, which we all do. We are constantly assessing our patients. We should be always assessing. We should watch out for subtle changes. That's how we catch things. You're always making those systematic observations. Your mind's got to be like a steel trap to catch anything. See? I keep my pulse on my students because I want to sense what troubles you. You see, that's the seasoned nurse that I have become. As I say, my students have become my patients. You know, it's sort of a twisted sense, but I do a lot of times I'll slip and I'll say my patients, and I say, oh, I mean my students. You know, I do that. I don't know what's gotten into me. It's over the past few years I've been doing that. Example of an ongoing assessment. We had this in Skills Lab, right? We had a situation, not maybe temperature-wise, but I think it was something with the blood sugar. Had a non-compliant diabetic. Ongoing assessment revealed they became shaky and dizzy, and right, y'all remember? And of course I took care of it. I was playing the doctor, and I said, well, we played this, we did a role play, right? And so I like to cut to the chase, because this is a typical order that the doctors would order for a patient that's having a hypoglycemic reaction. And they would order, give half an amp of D50, check that AccuCheck every 15 minutes. As long as that, if the AccuCheck's less than 70, continue giving a half an amp and keep checking the AccuCheck till it gets greater than 70. That way, you're not wasting time. You're constantly reassessing and you're getting the patient's hypoglycemic episode corrected. These are typical kinds of orders that a doctor will give you. Comprehensive assessment. It's a global assessment. It's a holistic assessment. It covers all these attributes to include the culture, the belief system. So the patient's family, economics, status, socioeconomics. That's a comprehensive assessment. You have a focused assessment. A focused assessment is they're looking at a particular problem, particular area. They're focusing in on something. An initial focus assessment might be like a follow-up to a client-reported symptoms or something unusual found in the first examination. Here's an example, and it's a true example. It's what happened to my mom. My mom never had a history of cardiac, as far as I knew. And she calls me at my house, and I just so happened to be working a 3 to 11 shift. And she's elderly. She lives 3 blocks from my house. And she calls me and she says, Linda, my chest is hurt. Fortunately, I heard the call. It was just the chain of events that happened. And I go right over to her house, and yes, she's having these classic signs. She's diaphoretic, she's pale, and she's clutching at her chest. She's just a tiny lady, about 90 pounds, about 5 foot tall. I said, take this aspirin. She's starting to retch, see. I said, she can't take that baby aspirin. I said, let's get this aspirin. I said, let me get you in the car and get you to the hospital, Southeast Baptist. I can't make it. I said, well, I'm going to call 911 because I know what I see. So they arrive, and they have these routines I guess they have to do. They have to check the blood sugar, and they have to do all these things, you know. When I'm looking at her, she's having a heart attack, you know. But of course they subsequently come to that conclusion too once they hook up the EKG and they see the elevated ST segment, which y'all will learn about. So I'm trying to get them to ship her to the University Hospital on the north side, because that's where a doctor practices. And they said, oh no, we're going to take her to Downtown Baptist. So they take her to Downtown Baptist, and she's talking, you know, and she's just saying, well, hurry, if you're going to do something, you better hurry up, you see. And I say to my mom, and this is before they arrive, you know, because I can tell this is something bad. This is something bad. And I tell my mom now, because, you know, with my doctorate degree, I delve in near-death experience and deathbed visions, you see. And she knows it. And, you know, I'm trying to make a little light of what's going on here, but because I know it's bad. You know, I said, now, are you seeing anyone? You know. And she just looks at me, you know, and doesn't say a word. So my thought is maybe she did. And so they transfer her, or transport her down to Downtown Baptist to the ER. They were able to get the aspirin in that baby aspirin. By the way, the EMS were able to get that thing in her where I couldn't get her to take it. So she's in the ER, and they ask why she's come to the ER. She started having chest pain. Nurse obtaining the objective information about the pain has it on a scale system, right? And on a scale of 1 to 10, and my mom, she doesn't even let her finish the sentence. It's a 10, it's a 10. Unfortunately, things did go worse for her because that was the last time I ever talked to my mom. She went to the heart catheterization, they elected to do a heart catheterization, and she never woke up again. I don't know what happened in there, but it must have been bad because she went in talking, you know, she's having her chest pain, and she came out with unresponsive on a ventilator and on a balloon pump. Never woke up. So never found out, but I suspect highly that she must have had some severely blocked coronary arteries that I was not aware of. Because she was so active, see. And this was the first. So you never know when your last day's coming. It's something to say. But that initial focused assessment, that was gauging the pain scale, And she said, it's a 10, it's a 10. If you're gonna do something, better do it now. That's the way she talked to them. She talked to even the cardiologist in that ER. I'll never forget that way. You better hurry up if you're gonna do something. She knew. It's that sense of dread and impending doom that these cardiac patients will have. You guys will get that when you go to Adult Health 1, I guess. So nice way to, or nice segue into pain management. Y'all won't forget this because pain assessment, it's the fifth vital sign and it's very, very important. We used not to, years and years ago, it was patient has pain, we give them some medicine and that was it. But we realized we were not adequately medicating our patients for pain. And that's why it became such an important aspect. And actually Joint Commission, these accreditations, they look for that. They say, are you having your patients comfortable? Do you ensure the comfort? And hence that's why that's become the fifth vital sign. You have these things called functional ability assessments. And if you ever looked on the internet, you could find some of these different tools. This Hartford Institute research, dedicated to doing research for gerontological studies, and they have all these different types of assessment tools. Here's just a few tools identified: CATS Index, ADL scale, Lofton, and this Karnofsky's performance scale for palliative care settings. Now, we could go to that www.davis, I'll put it on there. You guys, actually where you find this is in that CD. You'll find the resources. And what that is, that'll provide you all these different tools. You'll look in there. Actually, when you go in there, you'll find the that CD's pretty good because it also gives you the NANDA, nursing diagnosis. You click in there. So I won't click into that website, but I did provide that for y'all. That's just an example. You see, is this thing? Oh, it's going to work. Oh, there it is. I have to hold it down. That's that example one of the pain scales. Faces. Special assessments. We might have to do some special assessments based on the situations going on with our patients. A lot of times you do have those nutritional assessments. They're not eating. What can we do to help them start eating? Because, you know, a person that doesn't eat, they lose that interest in eating, that desire to have food, and then that can create serious consequences. Always consider the spiritual assessment. Spiritual assessment is very important. Person in spiritual distress, see, it wears on the body. It does, if they're in distress spiritually. How we can help our patient in all things, that's what we must consider. We're the RN that's supposed to be all-encompassing in our assessments and care. Holistic. Y'all, if you have any free time, sometime look up Jean Watson, nurse theorist. I wish when I grow up to be like her. Her model was on human caring. And she actually went to school in Virginia. Nursing school started off about 100 miles from my little town. Okay, so comprehensive assessment, it includes a nursing history, physical exam, physical assessment, and within the physical assessment, and I know y'all haven't had these aspects, but we will be covering it in the skills lab. We will be. These are different techniques that you'll use as you perform your assessments on your patients. I just put a little memorandum there on a certain type of assessment, circulatory assessment. That it doesn't hurt. We talk about interviews. Interviews can be direct or non-directive, open, closed questions. And I sort of like the cartoon and I couldn't resist. I can't give you my cell phone. If you need assistance, just use the nurse bell. Closed questions. They're useful when patients are having difficulty. We have to be direct. I know in nursing it says, oh, we should ask all these open-ended to explore and try to get as much as possible. But there are times where that's just not the right time to be using open-ended questions or communication. Somebody that's in severe pain, do you think that they want to elaborate on anything? No. So you want to try to utilize that kind of closed-ended questions for situations like that. When you think about open-ended questions, you're trying to get that individual to expound on something. Person, maybe the open-ended question would be, well, what happens when you have a headache? Whereas the closed-end, when did you get the migraine? See, when? Because that's a pretty short answer. But this one is you're exploring what happens. But like I say, open-ended is not for a person when they're in severe pain. Let's not go down that path. Let's, you know, they're liable to smack you silly, right? Use some common sense. You know, common sense is critical thinking. That's what I call it. You know, I guess they didn't think common sense was a big enough academic word. They had to come up with something else. Common sense. A lot of nurses, that's what you, after you get your experience and you know what you're doing, you go with your common sense a lot. And it's usually the correct methodology. When we're doing interviews, it's just like when we're having any kinds of communication. You know, people know if you're interested in what they're saying, if you have good listening skills. You want to consider the best methodology when you conduct an interview. And one way is your posture. Are you leaning towards your patient or the person you're interviewing? Do you show interest? They can tell. And again, if you go to page 48 in your textbook, it'll give you some examples of techniques, methodologies of listening, and also those open-end and closed-end type questions for you to consider. Maslow. See, you know, you probably would think I would put the Maslow's triangle, but sometimes I like to tie it to who the person was that invented the Maslow's hierarchy of needs. Y'all learned that in psychology, right? Yeah. So you remember this triangle, and you see the triangle. But that's the guy that did it. Abraham Maslow. Hierarchy of needs. Basic needs must be met before we can address others. Physiological. We cannot survive without oxygen, water, food, shelter. That's basic needs, right? That's what's key. We got to take care of that first. Without oxygen, I will not survive. I am a patient that's in respiratory distress, and I don't have any oxygen applied. I'm just on room air, and the nurse is not paying attention. I need oxygen. I will arrest. I will die. Then the next rung, safety, security, love, and belonging, esteem, and cognitive, aesthetic. And then finally you get to the very top of self-actualization. We always try to achieve to get to that top. When you're considering self-actualization, it becomes and I'll speak in terms of finances.